My name is Samir. It's really sort of an honor to be up here after having been in the audience a bunch as a student and actually giving a talk on a substantive topic. Unfortunately, after having heard all the talks today, I'm probably the least qualified speaker to be up here that you will hear from. But the good news is you've all just had lunch, a little bit of food coma, and if we play this right, no one's going to notice. So Beth asked me to talk about single payer. I did a few debates with another Benjamin Rush Institute supporter in New York with Physicians for a National Health Plan on single payer. And I thought, great, I'll do this talk. I've sort of done this in a debate format. And then I realized this is a very big topic. It's a topic that could be sort of a whole weekend's worth of lectures on its own if you really wanted to dive down. So we're just going to try and do sort of a high-level overview of major themes. And I hope to leave a lot of time for Q&A, discussion, and comments. So we'll go from there. So during the session, what we're going to do is we're going to talk about the basic taxonomy of what people are talking about when they use the term single payer. We're going to identify where you see systems with these features in the United States. And then we're sort of going to go through the major dimensions along which you can compare any sort of healthcare system. And obviously, this is just a selection. What's interesting about talking about single payer is that it forces you at a very high level to think about everything about how you would design a healthcare system were you, in fact, trying to design one. And then we'll talk a little bit about resources where you can get more information, and then we'll sort of see what sorts of things you want to talk about more. So the way we'll do this, what is single payer? What is free market healthcare? We'll go through some of the data on costs and outcomes. And then we'll talk about how single payer systems compared to other systems might handle the trade-offs that happen within healthcare. What the adoption of a single-payer healthcare system in the United States might mean for trade-offs between healthcare and other social goods. We'll talk a little bit about politics. As a foreigner, maybe I should not be talking about elections, but I'm not Russian, so I think that's allowed. And then we'll talk, it's just gotten really dicey these days. And then we'll talk about, innovation, sclerosis, and systems designed for improvement. So what are people talking about when they talk about single-payer systems? PNHP are sort of the major representative group pushing for single-payer in many forms in the United States. And so, when I talk with friends and colleagues from that organization, you get a lot of different sorts of definitions. And, sometimes these distinctions are sort of arbitrary and don't really change the underlying point, but it's sort of helpful to think about payment versus provision of services. So one question you can ask yourself, is this something that could fairly be called a single-payer system in a way that other people would understand it is, does the government sort of have a monopsony on purchasing major healthcare services from its providers and then a monopoly on providing it to the public? And you can use that term monopoly loosely or strictly. And then relatedly, is the government the entity that's directly employing physicians and other providers that's directly operating the healthcare facilities? Most of the time when people are talking about single payer, they're talking about something like the Canadian model, where doctors and hospitals are not government employees in government facilities, but are paid through a government financing scheme. There's a lot of different permutations. People talk about the Canadian healthcare system. I like to say that Canada really has, at least 10 different provincial healthcare systems. They have to conform to common federal standards, but there are important differences in the way that services are covered or not covered, the way that physicians are paid, important differences in whether or not a parallel private system is allowed to exist. And the more you get from sort of high-level discussion of what kind of healthcare system do we want to how do we actually implement it, these details become more and more important, just because they force you to start to accept some real trade-offs. The obvious contrast that comes up, and this was part of the debate that Ray and I did with PNHP, is talking about free markets in healthcare. So what does a free market look like? For those of you who have not met Ray Rod, these next 3 slides are stolen from him. He was my co-debater. He's a psychiatrist also based in New York, great friend of liberty in healthcare. The way he likes to put it is that in a free market, the customer is generally free to choose the service, to choose who they're going to get it from, to spend their money and bargain over a price that they know, and to make trade-offs. And similarly, the supplier of a service, not just healthcare, but in general, is free to determine what service you're going to offer, what price you're going to offer it at. Right? Simple enough. So do we have a free market in healthcare in the United States right now? No. Can anybody name a regulation in healthcare? I've given you a barrel full of fish. Someone go, or I'll start picking. Come on. Shout it out. HIPAA, all right. EMTALA, nice.
Trap clause.
Say again?
Trap clause.
Trap clause.
The restrictions on abortion providers.
Restrictions on abortion providers, there we go.
Another regulation.
Right, so when we had our white coat ceremony at my medical school, our dean said, you know, you're entering into one of the most self-regulating, self-governing professions in the country, and talking about the responsibility that comes with it. This is 10-point font. I don't know if you can read it. This was sort of the list that Ray and I came up with in about 45 seconds a couple of years ago, just for kicks. I'm not going to read it because I don't have time for that, but you know, we don't have a free market in healthcare in the United States right now. A lot of these regulations are things that we may well want to have in some form, but whenever people start talking about single payer, the reason I bring this up is because oftentimes it's often framed in opposition to the free market that we have right now. And it's a whole other talk that we could do about just going through many of the things we don't like about healthcare in the United States and tracing aspects of it back to some regulation or to some feature of tax law design that was oftentimes very well-intentioned, in fact, I would say exclusively well-intentioned, designed to help people, and didn't really succeed in that goal. So, how many of you have seen a PNHP presentation? Because they're sort of the gold standard for making the case for single payer. Okay. So they have a very well put together, you know, set of slides that they usually use that, you know, I've had the opportunity to see and discuss with them a bunch of times. And, you know, they present a lot of data, and, you know, you can sit there in the audience and say, well, there's a problem with this, and a problem with this, and a problem with this. And so this is sort of my cathartic attempt to try to do this with some of the things that you will hear about single-payer systems compared to the American system especially. You know, I'm not going to spend too much time on this, but I think these are also sort of important things to hear. So things you might hear from advocates for a single-payer healthcare system is that in the United States, we have a problem with healthcare, or we have problems in healthcare that could be fixed by adoption of a single-payer system or a more government-driven system like we see in the rest of the world. Such problems as an abysmal rate of infant mortality. Who here is familiar with the statistics on infant mortality and where we come in? I see 1, 2, 3, a few. Okay. We're like number 20 or something, right? So when you look at infant deaths per, you know, 1,000 live births, we're something like number 20 in the world or developed world. It's not a very flattering number. And then you start to look at the World Health Organization, which maintains these statistics. They get reports from, you know, national statistical agencies. And as makes sense, every government has a slightly different way of keeping statistics that makes sense for them and how they report it. So do you count a baby born at less than 22 weeks as a live birth? Do you count a baby with a birth weight of less than 500 grams as a live birth? Do you have just a lot of really unhealthy mothers for reasons that you can't really treat after they become pregnant? Do you do better with normal birth weight babies? How do you do with the sickest of the sick, the really tiny preemies? So when you break this down, you know, the United States still has excess predicted mortality. So what this is showing the infant mortality rate disadvantage. I think this is 2012 data in terms of excess deaths per 1,000 live births relative to these 4 countries, Austria, Belgium, Finland, and the UK. And going from left to right for each one, so all births, an excess of 3 deaths per 1,000. But when you limit it to gestation of greater than 22 weeks, that drops a little bit. When you limit it to gestation greater than or equal to 22 weeks, 500 grams, and single pregnancy, because the United States has much higher availability of assisted reproductive technologies that result in higher rates of twin or even triplet gestation that are intrinsically higher risk, that disadvantage actually drops off considerably. It's still there. You know, I think one of the things that unites everyone in this room is we all see room for improvement in healthcare that needs to come from the systems level. I'm not trying to make the case that, you know, the United States is the best in the world, but, you know, the disadvantage erodes. And so a lot of the things that you'll hear about this are not painting maybe the picture that they claim to be, right? So in a similar vein, and we'll look here at infant mortality, when you look at normal birth weight babies, the US is the orange line. These are, again, deaths per 1,000 live births compared to Austria and Finland. 1 day, 1 week, 1 month, about the same. 3 months out, babies at home. 6 months out, babies at home. 1 year out, babies at home. And environmental influences begin to play a larger role because they're no longer in the confines of the medical system. Where it gets really fun is low birth weight babies, so less than 2,500 grams. We actually do pretty well at the early stages of life at keeping very sick, very small, very premature babies alive and to get them to go home. And this is, again, just sort of hammering home this point. Many more preterm births in the United States, many more low birth weight babies in the United States, and these are factors that are not really amenable to the sorts of medical interventions that you and I have learned how to implement in medical school. This is looking at adolescent childbearing rates, adolescent fertility it's called, against infant mortality. And it's a pretty good predictor of infant mortality. There's a lot of known health issues with teenage pregnancies that increase the risk to mom and to baby. And it's one of the many things that's not considered a typical target of physician intervention that explains a lot of this difference really well. So that's infant mortality. What about life expectancy? Our life expectancy is whatever number it is in the developed world. And this is because of our terrible healthcare system, and as a result, we should move to single payer to improve outcomes. Well, a lot of the gap comes from smoking. And remember, smoking tends to show up in the mortality statistics with a bit of a lag. So smoking rates 10, 20, 30 years ago, we're starting to see the mortality from that now, even though the rates of current smoking has dropped. Obesity, homicide, car accidents. One of the papers I was reading pointed out that the United States is a very large and very rural country compared to a lot of other rich countries. There will be a lot of passenger miles driven. How is this the fault of the healthcare system? I'm not 100% sure. This is a busy graph, and the red line is showing the trend for American states. The x-axis is the obesity rate for non-Hispanic white males in 2013, all non-Hispanic whites, age-standardized obesity rate in 2013, and life expectancy. And the blue line here is showing the trend line for other European OECD countries. And what you can sort of see is all these red dots are American states, and all these dark dots are, this is, Denmark, I think here, Austria, the Netherlands. And what you can see is that American states that have obesity rates similar to those in European countries tend to have similar life expectancies. And again, this is a single variable analysis. I'm not saying that this, settles the issue, but, it's suggestive of the fact that the healthcare system, the inputs that we have in terms of patient risks are oftentimes, what's driving these things that often get the American healthcare system and our modes of financing and delivery slagged. All the way down here, West Virginia, and this is what drives the American average here. Is that necessarily a set of things that reflects poorly on the medical care system? Well, we'll talk in a little bit about what do you want the medical care system to do. In terms of things that the medical care system can do, like treat influenza, we do pretty well. In 2000 to 2004, age-standardized death rates for influenza in patients 50 plus. I don't think we're particularly an outlier here. This doesn't seem particularly terrible in the grand scheme of things compared to other rich countries. So this is, again, just hammering home that same point. What percentage of the gap in life expectancy between, so in this case, I've chosen US males, what percentage of the gap in life expectancy is attributable to accidents, drug overdoses, and homicides? And the answer is about 85% of it. So you take accidents, road accidents, drug overdoses, homicides out of the picture, and the life expectancy gap with Scandinavian countries drops off by 60 to 90%. So when people tell us that we need a single-payer healthcare plan the way that these countries do, it's not really clear to me that that follows from when you actually look at the data in a way that's designed to show what the healthcare system is doing as opposed to environmental influences. This is another graph showing the same point. I feel like we're getting caught up. Similar thing, healthcare spending. How does the US sort of come in the world as far as healthcare spending per capita? Are we sort of, I heard someone laugh, I heard someone make a thumbs up. Higher. Higher based on what? Right, usually it's like per capita GDP, and then healthcare expenditures, and we're the one that's way off of the line. It's always a line. So I have a background in economics and econometrics, and so there's something called model misspecification. So when you have a bunch of data points that aren't in a line, and then you put a line on them, you're probably not modeling the data correctly. The other thing is that GDP is a very nice, vanilla measure of national wealth and properly national income. It includes a lot of things like exports and government spending and sort of business investment that don't necessarily reflect the material standard of living of everyday people. But there are measures for that. So one of them is called actual individual consumption per capita. And when you graph actual individual consumption per capita against per capita healthcare expenditure, what you see is something that doesn't really look like a line, and you see a lot of countries here sort of further down the development curve. And then we see our usual array of OECD-rich countries, and then we see the United States. And this is a third-order polynomial function, which for those of you who haven't had to think about this since Algebra 1, it's a function where instead of y is equal to x, it's y is equal to x cubed. And you know, this seems to fit everyone except for the US pretty well. And then the US, when you extend the model out, you know, it doesn't seem like we're that much of an outlier. You know, so maybe if you think of healthcare as something that people consume more of as their material standard of living improves, as other things in their lives become cheaper or easier to obtain, something that people may choose to spend more on. You know, think about what segments of socioeconomic status tend to carry with them the concern for gym memberships, organic foods, you know, taking your supplements, right? It's not unrealistic to think that the richer people get and the more they have in their lives, the more they might be able to or want to spend on their health. And this is what the cross-country data show. This is a fun little graph here. So this is sort of advancing as a little GIF, I don't know, hard G, soft G, a little GIF. So basically you take the same type of model, you know, this little x cubed function for the same type of data for all of the OECD countries for every year from 1970 until 2014. And you sort of take the US out of the picture and you just train the model and you say, here is all of the relationship between individual consumption and healthcare spending in these countries for these, you know, what is it, like 43 years, for all these countries except the US. Predict how much money is going to be spent on healthcare based on a country's, you know, individual consumption, sort of like individual, you know, material purchases. And so that's the x-axis. So this diagonal line is the model predicts, if a point lies on the diagonal line, it means that the model has predicted it exactly well. And what you see is that, you know, you look at actual individual consumption per capita, and it predicts healthcare expenditure per capita very well. And this was trained without the US, but then you add the US in and it predicts it for the United States as well. The United States is not much of an outlier. There it is. There it is. It's right on that line of perfect prediction. There it is. Not really an outlier. And you see, you go through the 80s and the 90s, and all of a sudden this proposition that the United States is an outlier in terms of how much we spend on healthcare, and as a result, we need to dramatically remake our healthcare system to bring it in line with other countries in the world, it doesn't really hold water, because when you look at a predictor that actually predicts what countries will spend money on, you know, it turns out, yeah, we spend more, but the answer is we spend more because we're much richer than most of these other countries, on aggregate measures, I should say. You know, if you look at GDP per capita or income per capita for so I think in 2013 was the last time I looked at this, the per capita income in the United Kingdom, if the United Kingdom was the 51st state, it would have been the 49th poorest state above Mississippi and Alabama. And this is something that we don't necessarily realize when we talk about the developed world. You know, at least by the sorts of things that show up in national income statistics, we are a richer country by a large measure than a lot of other rich countries. And the amount that we spend on healthcare is not necessarily out of line for that. Does that mean there's not a lot of waste and overcharging and other stuff? No, that's not what it means at all. But you know, it means that these aggregate measures don't suggest that something is necessarily fundamentally wrong because of the spending pattern either. I'm doing that thing I was worried about where I would get caught up in the numbers and miss the big picture. So let's talk about a few more, and then we'll get to some of the more interesting stuff. So who here has heard that Medicare has cheaper administrative costs than private insurance? Raise your hand. 1, 2, 3. Everybody's heard it. So they'll say that, you know, Medicare spends 3% of its budget on administration, and private insurance companies spend 15 to 20%. That sounds pretty inefficient, right? Except when you're administering a health insurance plan, your administrative costs tend to scale per beneficiary. It costs you some amount of money to recruit, enroll, keep someone on the books, send them a card every year. And then it costs you some amount of money to process a claim, regardless of the value of that claim. And so when you look at how that winds up working, when you look at these per beneficiary numbers, Medicare actually does worse, spending on average $60 to $70 per year more per beneficiary than private insurance plans, which, as was alluded to yesterday, shouldn't be that surprising because it's actually these private insurance plans that do Medicare's administration for it. And I find it very hard to believe that any profit-seeking company is going to say, I'm going to find a way to administer Medicare more cheaply than I'm going to administer something where I get to keep the profit. And this isn't even getting into, these administrative costs for private plans include things like having a nurse line that you can call to see if you should go to the ER, or wellness and prevention programs. Those are counted as administrative costs because it's not dollars spent going towards a claim. So some of these administrative costs are also desirable, including fraud prevention. So one of the reasons that Medicare burns through as much money as it does is that its fraud controls are sort of historically terrible, and there's every few years another major scandal, usually involving some vendor of durable medical equipment in Florida, and oh my goodness, how could this happen? So Michael Cannon at the Cato Institute told me this once. This is when he came for the malpractice debate at Sinai a few years ago. I love this. The administrative cost of burning $1 million cash is the cost of a few ounces of lighter fluid, and then the matches you get for free from a bar. Not all administrative spending is wasteful, but even if you assume it is, Medicare, which is sort of our single-payer little microsystem, really not microsystem given how big it is, our own little single-payer microcosm in this country, actually doesn't do well at all. And now we'll talk about some of the other stuff. So rationing was a dirty word growing up. The other dirty word in healthcare when I was growing up was American style. So I'm a Canadian. I've been in this country more or less since, 2005, still hustling for my next visa. But in Canadian political discourse, American style is sort of this like insult that closes the debate. Like, oh, you don't want like an American style healthcare system. Oh no, we're so much better. So there's a free market think tank in Canada called the Fraser Institute, and they have a publication, was it Waiting in Line, Waiting Your Turn, something kind of dour and gloomy like that, and appropriately so. And this is a graph sort of from one of their highlight publications. Wait times in 2017, the wait time here is from the time your GP refers you to a specialist for treatment of some disease requiring specialty care to the time you receive that treatment. If you go into the report, they break it down, wait time from GP to specialist, and then from specialist to actually getting the treatment. You'll see it's actually gotten worse in the 14 years since 1993, despite the fact that healthcare is always the single biggest political issue in Canada. It dominates the elections at the provincial and federal levels, more money thrown at it, lots of time and energy and newsprint devoted to the topic. And the wait times have actually gone up. If you can't see the numbers, this year in New Brunswick in 2017, 41.7 weeks. I just had lunch and not enough coffee, so I can't readily calculate how many months that is. But that's somewhere between the better part and the best part of a year. The best performer is Ontario, my home province, 15 weeks. So that's about 3.5 months. So these are real things. So to give a personal example, my dad recently, for some reason, someone sent a prolactin level on him. It was borderline high. And so someone decided, maybe he should get a brain MRI. Rule out a pituitary microadenoma, like, okay, fine. The wait time in Ontario would have been about 3.5, 4 months. And admittedly, this was not something with, much of a degree of urgency. Or maybe this is my optimism bias in that this is a member of my own family. But 3.5, 4 months for an MRI. Or he could find a place an hour away in Buffalo, New York, just across the border, that does a thriving business in catering to Canadian patients who don't want to wait, and get the MRI and the radiology read done there, paying cash. What do you think the cash price was, by the way, just out of curiosity? Cash price for an MRI and a radiologist to read it? $500, $900, $800, right? How much do you think if I walked into OSU Medical Center and said, I'm uninsured, cash pay, give me a brain MRI with contrast and read it, how much do you think I'd wind up? Right? A lot, 5,000, that's the number I'd expect, right? So it's crazy what you can do when you take the third party out of the equation. So this is something that sort of made the rounds on Twitter in the fall. For those of you who can't read it, it's from the Movement Disorders Clinic at Kingston General Hospital in Kingston, Ontario, about an hour, 2 hours drive from the national capital in Ottawa, and a 2 to 4 hour drive, it's been a while, to the provincial capital and major city in Toronto. Dear sir, this letter is to inform you that we have received your referral for so-and-so. Our current wait time for a new patient referral is approximately 4.5 years. As such, sorry. We will hold your referral and mail an appointment slip to your patient when one is available. If the delay is acceptable, we will keep them on our list. If unacceptable, alternate referrals should go to Ottawa or Toronto, assuming that they have a shorter wait. If you intend to make alternate arrangements for your patients to be seen elsewhere, please let us know as soon as possible so we can void the referral. Thank you. Kingston is about the size of Dayton, Ohio. Population around 150,000. It's not a big city, but It's not small. You know, and the way that these things come about is when the government in Ontario is the single payer, and it also sort of controls the supply of new entrants into the profession. One of the ways that you can avoid paying more for healthcare is simply to not license new physicians, not license hospitals, who are then going to generate bills that you have to pay. I suspect, though again, this may be some personal bias here, that this is one of the reasons that it's hard to get American training recognized in Canada, harder than you would think. You know, hospitals have their, even though hospitals are sort of private, they still get grant support from the government. Their capital budgets are controlled. So like all the hospitals in my old stomping grounds of Mississauga, Oakville, the other suburbs of Toronto, you know, they have fundraisers for their capital campaigns. We want a new cancer wing. We want, you know, a new scanner. And you know, there's still a lot of room for philanthropy to do these things because there's a lot of need for philanthropy to do these things. You know, we have a lot of inequality in outcomes in this country. A single-payer healthcare system would fix that. This slide did not translate well onto PowerPoint. This is a regression analysis showing the effect of income on the Health Utility Index, so a self-reported measure of well-being. And income has just as strong an effect for you know, Canadian patients and American patients. Richer people, people who are better connected, will find ways to get better care and better things. And I struggle to think of a more polite way to put this than this is sort of a reality of human society, and that power brings with it power and resources bring with it resources. And you can't even eliminate this in a single-payer healthcare system. You know, they've shown similar results with health outcomes in British civil servants, where the government not only pays for all of the health care, but delivers virtually all of it. Senior civil servants have better health outcomes than, you know, the lowly office drones. You know, and again, you know, I'm fortunate to be a relatively healthy person, but I do have a couple of personal anecdotes in this regard. You know, you have the one family member who's a radiology coordinator at one of the hospitals in downtown Toronto, and you find that you and your relatives, maybe she talks to the radiologist, squeezes you in somewhere. You know, that's not necessarily clinically driven rationing. That's not necessarily rational, but that's something that happens. I took a year between college and med school. I knew I was going to need to get jaw surgery done for TMJ issues. I was going to be wired shut for 8 weeks. I learned to love the blender. And you know, when I first called the oral surgeon, you know, in my old stomping grounds of Mississauga, Ontario, I called in like June or July, shortly after graduating college, and they said, okay, we'll see you for your initial consultation in February. And I said, I'm sorry, I'm going to med school in a year. What now? Yeah, we'll see you for your initial consultation in February. Fortunately, my dentist went to dental school with the guy. And I did not wait. I got my surgery in February. You know, is this a particularly virtuous thing for me to have done? Probably not. But you know, the reality is that as long as you have people and personal foibles involved, a single-payer healthcare system is not going to guarantee more equal health outcomes either. So that's all the, my gosh, we spent so much time on all the boring stuff, I'm sorry. So I think some of the more interesting stuff when you're talking about single-payer systems is trade-offs. And how do you make trade-offs, and who makes trade-offs, and who makes trade-offs for whom, and what priorities do you choose? So because you know, you're mostly first and second year med students, I've chosen some case vignettes. Your patient is medically appropriate for discharge. Their family is still trying to decide which of the 3 skilled nursing facilities that have been offered they'd like to send their relative to. Does she stay an extra night in the hospital so the family can decide? Should she? Do you kick her out? The patient might prefer it, the family might prefer it. Is it more expensive, or is it just an accounting artifact that it's more expensive in the hospital? Does it impede system throughput? Who makes the decision? Who should be allowed to? A brain dead patient's family. There was brain death as a concept actually is, here we go. A brain dead patient's family informs you that their religious beliefs do not recognize brain death. That as far as they're concerned, if the heart is still beating, their loved one is alive. The patient remains in the intensive care unit receiving maximal medical therapy. So, right, trade-offs in this case between patient family beliefs, maybe provider beliefs and provider conscience about, you know, how do we treat this patient? So who makes the decision? Who makes the trade-off? Your laboring patient, this is a fun story. Your laboring patient with worsening severe preeclampsia, a you know, dangerous condition for which the treatment is delivery via cesarean section. It's determined that she's at term, she has worsening severe preeclampsia, seizures are a bad thing, so she should get an urgent cesarean section. The time is 10:30 p.m. and she doesn't want to go until after midnight so that she gets an additional night in the hospital. So you're the insurance company, and you get a claim, and do you pay for that second night? Should you? Is this, why are we billing by the night? Right? Lots of trade-offs in medicine. So a patient experiences a complication from what was supposed to be a routine ambulatory procedure. Things don't go well. Stuff happens. They land in the ICU. Patient does better. Breathing tube comes out. Pressors come off. And the patient says that I was going to go home to my home 100 miles away right after I came here for the procedure. Can't you send me to the ICU there? Right, so the patient would like to go home. The hospital maybe wants to keep the revenue. There is some risk in an ICU to ICU transfer. If the patient wants to bear the risk, is it okay? If the patient wants to bear the cost of the transport, is it okay? Do we let them or do we not? Here's another fun one. Some of these are based in my own intern year, by the way. I won't always say which. You're asked to come to the hospital, or I ask you to come into the hospital at midnight to place a chest tube in a patient who's had significant hemorrhage into their chest cavity. Why did the patient have significant hemorrhage into their chest cavity? Well, they coded and vigorous CPR was performed and some ribs were broken and some bleeding ensued. The patient's not going to survive the week. This invasive procedure is not going to improve a thing about them. But right now the ICU is saying that because their oxygenation is so poor, the patient's not even going to tolerate being transported to the intensive care unit. But if you come in and put this chest tube, maybe we can at least get this patient off of the regular floor where the nursing teams are overwhelmed, where the intern who's covering 50 other sick patients is overwhelmed. And maybe the patient can go to the critical care setting, or at least until the family is called and things are decided, this can be sorted out. So, so you do the procedure, and this is immediately going to count as a 30-day mortality if you're the one putting in the chest tube. This is going to be one of those statistics about an invasive procedure done on someone in their last year of life. And this is actually one of the times where we know it's their last year of life in advance. Oftentimes I see this and I'm like, well, how do you know when it's their last year? You don't always. We know. So do you do it? Should you do it? Should it be done? Should it be allowed? So with a lot of these trade-offs, the issue is, and I've deliberately chosen cases here without always easy answers, but there are trade-offs here, sometimes between competing clinical priorities, sometimes between what patients and family members want and what you as a clinician would advise, sometimes between institutional priorities and other priorities. And they come up a lot in healthcare, and I'm not convinced that a system with a proclivity to centralize and to issue thou shalt and thou shalt nots, and that doesn't leave the patient with any meaningful role in the game, because as we know, skin in the game, paying the piper lets you choose the tune to some extent. I'm not convinced that any sort of system with a tendency to greater centralization is likely to result in more humane, patient-centered outcomes than a system where decisions are made more at a local level. And I'm not saying that what we have right now is great at any of these either. A lot of the decisions that come up here, the quandary comes up because of risk management issues, malpractice issues, regulatory issues. I'm not saying that what we have right now is a system that handles these particular issues well. But oftentimes the problem is some rule, some policy, some standardized procedure that makes it very difficult to handle these situations sensibly. And whenever you're designing any kind of healthcare system and you're thinking about who's making the trade-off, how centralized is it going to be, how much flexibility do we give to people at the actual point of care, in some respects you're asking yourself, how are you going to handle the hard cases? And hard cases make bad law, as the saying goes. That doesn't mean you should forget about them entirely. So similarly, single-payer healthcare system, we want everybody to have access to basic, essential healthcare. So what's essential healthcare? Before Obamacare, states had their own minimal essential benefit requirements for health insurance plans that covered some things you would expect, some things that you wouldn't expect. And this is something else that, what would any of you consider any of these things essential, nice to have, maybe? Right? If it was considered essential and you really had a problem with it, but that's okay because that's not your insurance plan until there's only the one insurance plan. So these sorts of trade-offs, some of them, I have glasses instead of contacts or instead of getting LASIK, and that's a trade-off I can make at the personal level. Some of these trade-offs, we make by choosing a private party like an insurance company, a healthcare sharing ministry, an employer that says that they're going to cover certain things, maybe not prioritize other things as much. Or you can outsource it to the electorate. And I know of very few people who are happy to routinely outsource their personal decisions to the electorate. I know plenty of people who aren't happy outsourcing personal decisions to their close family members who might have strong opinions otherwise. So this here is from the Oregon Health Services Commission. So Oregon actually has a very intellectually honest way of doing this in their Medicaid program. So what happens is there's this Health Services Commission, and they sort of group together. I looked at the most recent list. It's like 500-600 different types of healthcare procedures for certain diagnoses, and they use this alphabet soup of diagnosis and procedure codes, and then they rank them by priority. All right, so priority 1 on the list, I think, was pregnancy. So we want the Medicaid program to cover pregnancy and these pregnancy-related procedures and treatments. And then it sort of goes down the list, and they provide cost estimates, and then the legislature decides, here's the number at which we're going to draw the line. So I think this year it was like a 500-600 item list, and I think the legislature drew the line at like 180 something. And everything below that line is presumptively not covered, and everything above that line presumptively is covered. Which, if you're going to design a plan that's going to pay for healthcare for millions of people you don't know, I think actually is a very reasonable way of doing it. If you're one of those millions of people, you might prefer an approach that lets you decide which of these things you'd rather have paid for and which of these things you'd rather not. So again, who's choosing what for whom? And these are things to think about when you're designing a healthcare system. But this has all been talking about health and healthcare. And remember, we talked at the beginning, I went through all of those, slides that were very complimentary to the state of food coma that we're all in about, is our infant mortality rate so bad? No, well, because, our moms are unhealthier. Is our life expectancy worse? No, because we get into more car crashes and shoot one another more often and don't eat well and used to smoke more. And this was sort of, alluded to, yesterday, where, a lot of what we do as physicians doesn't really matter in the grand scheme of things, right? The things that are going to keep people healthy day to day is not a daily visit to the doctor, but it's the stuff that we all sort of know. Don't smoke, exercise, eat well. So, right? I mean, you've all learned about the social determinants of health. That phrase rings a bell. You guys have heard estimates of what percentage of health status is attributable to social determinants? Throw out a number.
It's 80.
80, okay. I would give you credit for it, but Beth beat you by half a second. It's okay. So 80%, right? 80% of sort of most measures of health status are attributable to environmental factors. Cancer specifically, right, which we think of cancer as, like a medical disease that emerges from within the body and we treat with all the cutting edge stuff. There was a study, I want to say in JAMA in the last few months, estimating that 40% of cancer deaths have a significant contribution in one form or another, whether the incidence of the tumor itself or response to treatment, 40 to 45%. So first of all, why are we chasing our tails so much and devoting all this time and energy and newsprint to the little fraction of the margin where the medical care system makes a difference? Most estimates for single-payer healthcare plans in the United States estimate that it will be more expensive to administer, or certainly it will require an increase in government spending. So in New York, I think I had this written down. So in New York, they estimated that one of the single-payer healthcare plans that was put forward by whatever the state-level version of PNHP is, would have required a doubling of income taxes in New York just to pay for it. Vermont was toying with a plan of its own a few years ago, and $45 billion of hole in the budget later, they decided maybe it's not the greatest idea. It's one thing for us as physicians who go to med school and, we like this, we obviously think it's important and everything to say, yeah, of course, we want people to be healthy. We should spend all this money on healthcare. What's wrong with that? Well, what's wrong is that, states and governments and society do a lot of other things besides just healthcare systems. And the more resources we as a society, whether it's through private expenditure, whether it's through government expenditure, the more we pour into healthcare, the less there is for other things. And what we've seen is it's the other things that actually make a big difference. And right now, what a lot of you are probably seeing in medical school is right now they're trying to teach you to be a professional doctor, an amateur social worker, an amateur health coach, an amateur nutritionist. But we have professionals who do those things. But the reason that this is happening is because everyone's sort of viewing health through this prism of medical care. We're going to make people healthier by getting them in front of the doctor. Well, the doctors don't know how to talk to them about food. All right, so we're going to give the doctors 2 hours of lecture in medical school, and then they're going to know. That'll show them. They'll improve everybody's diets. They'll become experts in motivational interviewing. If they go into a family med residency, we'll teach them some more. And it's a very warped thing that I think is happening in medical education. Now, again, I come from an acute care specialty. By definition, every one of my patients is critically ill, or they're going to be within 30 seconds of my pushing drugs on them. So my bias is that, like, do I think medical school was useful, like, compared to my friends who went into internal medicine or pediatrics or surgery? Yeah, because I take care of very sick people, and I know how the human body works, and I know what I can do to fix it. And I think this is where our comparative advantage is, not in trying to solve all of society's ills with this base of training we got that it was never really meant to. So a few more things. How am I on time?
You've got,
I have time.
yeah, about 10 minutes.
Okay. So other things, so like I said earlier, in Canada, the number one issue in every election is healthcare, healthcare, healthcare. I guess recently in the news, it's been like Justin Trudeau. Have any of you guys seen this? Like Justin Trudeau's like Bollywood costume vacation to India, and then he brought like a convicted Sikh separatist terrorist with him, and it would be funny if it weren't so just terrible. No, he went to India for like a week, had like one day of official business, and the rest was him and his family, like dressed like, they're dressed up for like the wedding in a Bollywood movie, and everyone's just sort of like, so when that's not happening, healthcare is usually the biggest thing on the news. And so in addition to doctors making better doctors than nutritionists and social workers, doctors make better doctors than they do lobbyists, and doctors make better doctors than they do street protesters. And it bothers me so much that everything here matters. It bothers the hell out of me that I have to know any of this. It bothers me that I have to know what MIPS and MACRA are. It bothers me that one of my research projects, it's like a fun little research project, I'm learning a lot, but the subject matter is like, how are we doing with our departmental compliance on one of these MIPS quality measures? Like, we could be spending our effort on something that actually matters. But instead, we're spending our effort lobbying government, either asking for some special privilege or trying to avoid getting squashed by some unintended or intended, move in the healthcare space. We're spending our time documenting and reporting on things that, maybe these are worthwhile things, maybe these are things we should be doing, but we're filling out the paperwork for the sake of satisfying the person who issued the paperwork. Have you guys seen this at all in medical school? Right, or in your own personal lives or your professors? Like every time I get an email from the American Society of Anesthesiologists, we're having like our annual legislative day lobbying in DC. It's like we could be doing so much more. So and the more you bring the healthcare system under government control, the more this becomes required. And the more you're taking your medical education and your desire to care for patients and your desire to hopefully advance the state of scientific and medical knowledge, the more you're taking all of that and you're wasting it on transactions costs, right? It's like a hidden tax on your time and energy for being in the profession. You have to pay your dues. You have to kiss the ring. You have to check the boxes. It bothers me. Like my research project is actually very fun. It's going to be a cute little paper, but like why couldn't it be on something that matters, And then the last thing, and this is something I brought up. So when I did this last single-payer debate, it was in October of 2016. And I told the students at Albert Einstein College of Medicine that, I'm a Canadian, I only know so much about your politics, but I understand there's a very bad hombre running for office right now. He'd just gotten in hot water for using that term to describe, people allegedly coming over from Mexico who were bad hombres. So the joke sort of worked then, sort of. And this is something that maybe is more unique to the United States. In Canada, to the extent that single payer works, and in the UK, the extent to which their system works, and in most other countries, it works because there's a lot of social consensus and social buy-in, and a lot of political consensus and a lot of political buy-in. Now, obviously, this isn't a be-all and end-all argument. People can be persuaded, positions change, but I think it's fair to say, comparing political culture in the United States to most other countries, I think there's just going to be a substantial number of Americans who will never want a single-payer healthcare system. Most of those Americans tend to cluster into one of your two political parties, and every now and then, one of these two political parties will win an election or two. And if you remember earlier this year, people talking about how the Trump administration was sabotaging the exchanges, sabotaging Obamacare. Well, what happens when, President Sarah Palin, who you may or may not like, but, most of my interlocutors in New York would not. What happens when President Sarah Palin decides to sabotage the single-payer healthcare system that you've set up, and that's the only game in town? And if anything, the degree of political polarization, political divergence, divergent values, I don't see how you can honestly advocate for a single-payer healthcare system and then, and the Republicans are going to win elections every 4 years. Have you thought about that? We'll figure it out. It'll be too popular for them to mess with. I'm not sold. I'm not sold. And I have everything here I've said to people who believe in single payer, there's usually some good discussion about. This is the one thing that nobody really has an answer for me on. Like, how do you politicize all of healthcare when half of your politicians will do things with it that you don't like? Or let's say they keep it and they ban abortions, or they fund abortions, or they, whatever politically sensitive healthcare-related topic, you want covered or not. Except now this is the only game in town, and this is where everybody gets their healthcare. So sorry, you're stuck with it for 4 to 6 years until, the House changes parties again. And so then the last sort of theme I want to talk about when comparing different types of healthcare systems, I'm not pretending, or at least I hope I'm not seeming to be pretending to have the right answers about how we should structure healthcare. Unless I want to be difficult, I try not to pretend that I have all the answers. Sometimes I do try to be difficult. But, even if we assume that we could switch to a single-payer system and all will be well with the world and our costs will come down, which they won't, and our outcomes will be better, which they won't, we have a lot of examples in this country of, forget government and private sector, just small groups versus large organizations. Who moves quickly? Who makes changes? Who adapts? Who fails fast? Who coins the term failing fast? The answer is not usually the large organization, and large organizations have their roles to play in civil society. Government has its role to play in civil society, but governments and large institutions, by their very character, tend to slow things down. They tend to cause sclerosis. They tend to codify. They tend to make it hard to change things. And there are some areas where maybe that's a good thing, and you might not want people experimenting and failing fast with the murder laws. But in healthcare, that's not necessarily the case. And so I can think of, since starting medical training, a whole bunch of things that, if a hospital had decided to do it on its own, or a group of hospitals had decided on their own, okay, great, this didn't work, let's move on. But instead it became a CMS mandate, or a joint commission, which largely has a monopoly on accreditation because of CMS, a joint commission mandate. Pain is the fifth vital sign. Who learned that in med school, actually? I'm curious. Okay, because I remember when I was in med school, the teaching was, give them opioids, it's fine, opioids treat pain, opioids good, learn how to do it. And then I graduated and learned that maybe this isn't in vogue anymore. There used to be a rule that when you went to the ER with community-acquired pneumonia, you had to get your first dose of antibiotics within 4 hours. Here's the problem. Sometimes it takes more than 4 hours to sort of diagnose to a reasonable degree of certainty that somebody has community-acquired pneumonia, as opposed to a heart failure exacerbation or a COPD exacerbation. So until they got rid of the rule, people were getting unnecessary antibiotics to meet the measure. Do you guys sort of know MIP? MIPS and MACRA were alluded to before, but MIPS is sort of here are the process measures that you must report to Medicare for all of your patients, Medicare or not, in order for your Medicare payments not to be cut. So this is one of the ways that Medicare, affects everything. Like, we get graded, our Medicare payments are based on our process measures on non-Medicare payments as well. So some of the measures that come through there make sense. Some of them might not, and some of them might in a year or two, for each specialty. Maybe this isn't how we want to measure progression of this disease. Maybe this isn't the best way to assess physician performance, but government measures have a tendency to get entrenched. They get harder to change. Anytime you see a published guideline, by definition, that published guideline has been developed over the course of a few years, looking at several years worth of evidence, and it's obsolete the moment it's printed. And this is not to criticize guidelines. This is just the epistemic nature of publishing in time. And this is fine, except when you have government, and especially when that government, or that single payer takes the role of setting rules for everybody, you run the risk of taking these bad things and reducing the variability that lets you A, find out they're bad, and B, find out what's better. And related to this, how many of you are aware that we have a shortage of geriatricians in this country? Projected shortage, expected to get worse, all the baby boomers are retiring. Who pays for graduate medical education in this country? Medicare. What patient population is Medicare primarily charged with taking care of? Old people. Okay, the elderly, yes. So, when people like to compare government health care and alternatives to it, people will often talk about the free market as it is and government as it could be in an ideal world. And that's not an accurate or fair comparison, but with Medicare and the VA, we have our own little case studies, and it's not, I think, unreasonable to expect that moving to a single-payer system would take a lot of the problems that we've seen in these systems and just sort of inflict them on everyone, right? So the organization in charge of taking care of the elderly has managed to engineer a shortage of geriatricians. And this has been known for a while. This has been known for at least a decade. And, so, still have a little bit of time, right? So the one last thing, this presentation's gone a little out of hand, 3 minutes. All right, and so then one last thing on the subject of innovation. Right now a lot of clinical trials, a lot of delivery system innovation, a lot of innovation on ways to do things cheaper are happening outside the United States right now. But the fact remains that if you have a drug or a device or a thing that you want to sell and make a lot of money on, and if you need to make enough money to justify paying the $500 million application fee to the FDA and going through the clinical trials process, you need to sell that drug or that device to cover your average cost in the United States. And when you see that drugs only cost X amount in Canada or the UK or Slovenia or France or Japan, it is because you and I, the American patients and the American consumers, are underwriting those low prices in the rest of the world by paying the prices here that allow drug companies to earn their return on capital, to earn their return on investment, to fund their R&D, to cover that average cost and allow the thing to exist in the first place. So one of the other things that often comes up in discussion of single payer is that, if we have a single payer system, we can negotiate with drug and device companies and bring prices down. Well, not everybody gets to be the marginal price consumer. Not everybody gets the senior rate at the movie theater. Not everybody gets a student discount. Somebody has to pay for the fixed costs. Right now, that's us. I guess I'm technically Canadian, so right now that's you guys. When that's no longer you guys, what happens? So that's something else to keep in mind. The other thing to point out when people talk about that is that, Aetna, United, Cigna cover more people than most Canadian provinces do, so I'm sure they could negotiate if it were feasible. I don't know enough about that to say, but the idea that, scaling it up nationwide will make it easier to negotiate fairly, no, you're going to get price controls. So summary, because that presentation was I know, very wide-reaching. Right, a single-payer system is one in which the government is a primary or exclusive financier of medical expenditures. I think that's a definition that anybody in this conversation, regardless of their opinions, should be able to agree on. And so if you're going to talk about a single-payer healthcare system and sort of compare it to its polar opposite, at least in theory, it's this free market system of healthcare that we don't have right now. A lot of the data that show that single-payer, non-American healthcare systems produce superior outcomes are questionable at best, wrong or misleading at worst. Single-payer systems have a tendency to centralize and to take decision-making and trade-offs away from patients and physicians, who are ideally the ones who would be making these decisions in any system. Single-payer systems, by virtue of their increased costs, distort trade-offs within society as a whole about what to spend resources on, including other potentially more efficacious health-promoting activities. And then we spend our time and energy talking about this instead of talking about the stuff that's going to help you take better care of your patients. I think those are, and then there's a few others, but I think those are sort of the takeaway points from today. I apologize for the breadth of that. Questions, comments?
So why don't let's, I want to give Jules her full thing, and you talked your whole time up. So
that got long, she's fast.
Yeah? You want to give them a few of your minutes?
Yeah, but
Oh, okay.
Nope.
Great. Thank you, Jules. Questions?
So it seems like replacing what we have now with the single payer system would be like taking off one dirty shirt and putting on another dirty shirt, but people want change and we want something new for the sake of newness. So how do we approach that?
So I think people do want change, and people are right to want change. And I think that part of helping people understand why a single-payer system isn't necessarily going to be the best thing is, you can look at a lot of the issues in our current healthcare system, and a lot of them derive from regulation. A lot of them derive from Medicare in particular. Our shortage of primary care physicians and geriatricians. That's largely a result of mismanagement by Medicare. A lot of these things that hospitals do that lead Medicare patients to have higher bills by placing them in observation status instead of admitting them. That's a result of incentives from Medicare. Like the ridiculous way that we bill for office visits is a result of Medicare billing guidelines. So I think part of it is just helping people understand that what we have right now is a function of something that you're likely to get a lot more of if you adopt a single-payer healthcare system. And then I think a lot of it is just failure of imagination. I mean, especially being in an academic medical center, you're probably not seeing much direct primary care. You're not seeing, for me, the Surgery Center of Oklahoma, I show that website to my friends and I say, how much do you think our hospital gets paid by Medicare or Medicaid, plus the surgeon, plus the anesthesiologist for doing this surgery? And here's how they do it there. And yeah, fine, Oklahoma City is cheaper than New York City, but a lot of it is that, we've gotten so wound up in this idea that you need a third-party payer, that patients should not be handing over a credit card at the point of, or cash at the point of service. That we lose sight of the fact that introducing this third-party payer causes a lot of these problems that we're now seeing by distorting incentives and sort of by removing any real discussion of cost from the equation. So I think that just illustrating viable alternatives and showing that they are there and they do work, I think goes a long way to sort of pointing people towards a direction in which change would be helpful. So related to that, LASIK and cosmetic surgery are not procedures that have historically been covered by insurance. Yet since their introduction, LASIK in the late 80s, early 90s, and cosmetic surgery, I imagine has been around since the dawn of surgery, maybe not that far. Cosmetic surgery and LASIK are procedures that are paid for out of pocket and over time have gotten cheaper and better. And as it turns out, this is what happens in a lot of other areas of life, from the first computers with punch cards to the computers that we all now carry in our pocket, that when you let entrepreneurs, whether it be physicians or software developers or phone manufacturers, and you let people and entrepreneurs and groups in civil society actually try to solve the problems that their patients or consumers bring to them, we can usually get somewhere good if government sort of makes sure that there's the basic framework of a functioning society is there, but then stays out of the details. So illustrating that with real world examples, I think, is often a helpful starting point for that kind of discussion.
We kind of talked about this yesterday at the meeting last night. I'm wondering, so my clinical rotation is not just on surgery, and the chairman of the surgical board at the hospital is really promoting a single-payer healthcare system. But he says the government should stay out of it. He said there shouldn't be any profits involved. I'm wondering, so I use your approach and just kind of let him hang himself by the way he talks. So I asked him to explain more how that would be implemented. He really had nothing else to say about it. He didn't know how it could be implemented. I'm wondering how you would approach the subject, especially with that power dynamic, me being the third-year medical student, him being the chairman of the surgical board. And it's such a short, limited time frame.
Yeah, so that's something I'll talk a little bit about tomorrow. Actually, you'll be more. I will inflict myself upon you for another half an hour tomorrow. But we'll talk a little bit about that sort of thing. And you don't have to talk politics with everyone. Sometimes you just let them talk, and you say, "That's nice. Can you teach me how to tie a knot? What's the difference between Proline and Vicryl?" Actually, if you can tell me what is the difference between Proline and Vicryl. No, I actually do know, but surgery stuff, sometimes you just let it go.
Ask some questions to try and understand really from a place of authenticity. What does he mean by single payer? And particularly if he's saying a single payer where the government's not involved, because I'm really curious.
Yeah, who's the single payer if it's not the government, and how do you make sure that they remain the single payer?
I'm asking, at that point, with that kind of power differential, you will get much more out of trying to understand his position. And you'll probably learn what his real concerns are now, and what his perception of the problem is, his scope of understanding of the facts. And nobody has all the facts. Nobody has all the facts. But he's making that based on something. So I would just really do your best to honestly understand his thinking, how far has he actually carried it through? But not from a place of I want to go gotcha, but really of understanding what his thinking is. Yeah.
All right.
Okay, thank you, Samir.